Father in heaven, we do thank you that you are the great physician, that you are the one who calls us to be co-workers with you, and we pray that you'd continue to guide us as we spend time studying your counsel in the light of modern science, for we ask it in Jesus' name. Amen. Well, as we begin this segment, we're going to look first at the issue of recidivism, because it relates to some questions you've been asking me. I always find it most valuable to talk about things that you're wondering about. And one of the things that has come up in these meetings is the question of whether it's really valuable to put our energies into lifestyle change. And I put this slide up earlier in our time together before Dr. Dan spoke, and then you heard Dr. Dan present. And what you saw in his data, if you were here, is you saw two very interesting things. You saw what appeared to be a community-wide benefit from people going through lifestyle programs. If you're in a close-knit community and you send a number of people through, like a work site, you actually could have other people making similar changes. And presumably that's what happened. Someone could postulate, well, it wasn't anything like that. It was just that the community was getting healthier anyway. And there were other things happening in the public that were making these changes. But his interpretation was it was likely a health-giving effect from the program, not just on the individual, but on others around them. And when you heard his description of how the women in the family, what did they want? They wanted cooking classes, the spouses. So there was this community benefit. The other problem that we saw, though, is this concept of recidivism, or slipping back into the old ways. And there are many physicians who will not work with lifestyle medicine because they say patients will not follow these principles. Well, with that in mind, let me tell you something that is probably obvious to many of you, and that is simply this. If you're worried about lifestyle and people not following it, well, you should stop using drugs too. If you say you're not going to use lifestyle because not everyone stays on the lifestyle, well, let's look at how medications are doing. One of the most widely prescribed classes of drugs in the world are the beta blockers. This is actually looking at a study of medication adherence, particularly in the context of high blood pressure. So they're looking at the common classes of drugs. This was a paper published in the journal Circulation in 2011, so a recent paper. Most of these studies lasted 12 months in length or less. Look with me, if you will, at where the beta blockers stand. They're at the bottom of this list. They're abbreviated as BB. And you can see here that over two-thirds of the people that were started on these drugs were not on them a year later. So if you think that writing a prescription for a beta blocker is better than lifestyle therapy, now, I mean, this isn't a study that compares the two. I'm simply saying that there's a huge number of people in a very short time, even with drug therapy, who don't stick with the medication. And you say, well, Dr. DeRose, it's much better for the diuretics. Well, still, you put someone on a water pill, only half of those people will continue to take it within a short span of months or at most a year. And when you even get to the very best tolerated medications, the ones that people adhere to the best, it's still about a third of the individuals in a short time have stopped that medication. Now you might say, well, that sounds a lot better than lifestyle therapy, but I think it's still worth noting. But remember, this is just looking at a single drug for a single condition. What does lifestyle address? We're seeing that lifestyle addresses a whole host of conditions. And you have to keep that in mind. Let's look at another condition that is treated with medication, and these are the statins that are widely used for cholesterol problems. And again, this is data looking at adherence to statins, somewhat earlier in their history, but I still want you to see this very important point. This is looking at 1 calendar year again, just 1 year. And I want you to notice that within 3 months, many times in the United States, a prescription is written for 3 months. Many of the prescription programs give you a 3-month supply. Once you get to about 3 months, there's this huge drop-off. All these people that start on statins may maintain them for a month or so, but then within a month to 2 to 3, you're down to over half of the patients still on the drugs. And by the time you're out here a full year later, look at these numbers. I mean, in the best case scenario, only about 35% or a third of the patients still taking the cholesterol-lowering drug. What I'm trying to help us see is for individuals to tell us that we're not going to spend time with lifestyle because a lot of people won't follow it. Well, drugs have the same problem. Now, I'm not saying it's all to the same degree. A drug is a lot easier to take, if you will, than changing your lifestyle. But here's the interesting thing. Most drugs have potential deleterious side effects. Healthy lifestyle tends to have healthy side effects. So a doctor may prescribe exercise for your blood sugar, right? We've been talking about that. You may get a prescription. You may say, okay, you're pre-diabetic. I want you to exercise 30 minutes a day. You might have a side effect from that exercise that's beneficial. Maybe you're overweight and it's helping you lose weight. Do you see how that would work? Or maybe your blood pressure was high too. Your blood pressure is coming down. So we have to keep these things in mind. Well, what's really the problem then when we talk about this recidivism, this tendency to lapse when it comes to lifestyle? This is a very interesting paper published within the last year. Now, I don't believe the conclusions of the authors, but it's from the American Journal of Preventive Medicine. And here's the title of the paper, Health Behavior, a Darwinian Reconceptualization. And basically what the thesis of this paper is, the author is saying, we have all this data. We know that lifestyle is powerful. We know that it can reverse disease, but how come so few people change their lifestyle? So he's wrestling with this, and he's an evolutionist. He doesn't believe that God created us as the Bible specifies, and so he's coming up with his ideas. But I found some of the things in this paper interesting. I just want to look at one with you. It's actually two authors of the paper. They said when people do change their behavior to improve their health, it is often an unexpected and epiphanous experience. You may not be familiar with that word, Epiphanius, but it refers to an epiphany, or it literally comes from seeing God. So he's actually using spiritual terminology here, whether he meant it literally or not. And I'd like to suggest to you that we can't divorce the spiritual from the topic of lifestyle change, that it really is often most effective if it's done in a spiritual context. With that in mind, I find it particularly fascinating that we're using social networks. We're looking in the medical world at using social networks to improve lifestyle practices. We're saying, yes, this is a problem. What can we do to increase the likelihood that people, when they make changes, will stick with them? So there's a whole body of literature coming out. I just grabbed a couple of journals that were recently coming across my desk. This was one from earlier this year, January of 2013. And you can see the two top articles on this, Toward Healthier Lifestyles. That was page 1 of the 2013 volume of the American Journal of Medicine. And then Promoting Healthy Lifestyles to Children and Adults. What they're looking at in this particular study, they're talking about how we can move whole countries toward healthier lifestyles by reaching people in the social environments that they're naturally in. So for children, the social environment that they're in is, of course, the school. But this would apply to churches. It would apply to workplaces. And so there's a large movement that's trying to take advantage of social connectedness. Now, some of you wanted me to speak more in this session about blood pressure. I actually have a lot of material, and I wanted to see what Dr. Dan had to present. And we've been speaking about the diabetes more. But I have a whole series on high blood pressure that recently came out. It's produced by Amazing Facts. It is in English, but it's a 3-hour series called Reversing High Blood Pressure Naturally. So that's something that's readily available. So if you feel cheated that we didn't talk about that material here, you shouldn't feel that way because you can get that. If I presented that, you would say, well, why did he present that? I already have the video. So But if some of you want to have that translated, you may want to talk with Amazing Facts. That may be something that you could use. And I'll tell you how we use that reversing hypertension approach in reaching out to the community in a few minutes. But let's talk about social support and the example of blood pressure, because we have a nice example from Europe. Swiss researchers who looked at 22 individuals with high blood pressure. They compared them with 26 individuals who had normal blood pressure. And it was quite interesting. They found that there were some compelling social connectedness differences between these groups. They found those who had high blood pressure tended to have less social support, less perceived social support. Now, this is very interesting. It was looking at the perception of social support. So we might all be in this room together. We're all in the same social environment. But when I leave this conference, if we took a survey and we said, how much social support did you get in the conference? We were all in the same conference with the same people. Some of you might say, it was very bad. I got no social support. They treated me like I was an outcast because I couldn't speak certain language, okay? And whatever reason it was. So you were in the same environment. You said you weren't getting much social support. Someone else said they were. You said, well, that's understandable because there were differences there. How about in the same home? What I'm trying to help you see is you can't always measure social support just by external things. It does have to do with your own perception of social support. That is significant. Low social support, interestingly, associated with increased stress hormone levels. Do you see a parallel here between high blood pressure and what we were talking about insulin resistance? Do you see a parallel? Remember, higher stress hormone levels worsen insulin resistance? So we're seeing another strategy here to help people with insulin resistance. It's get them more socially connected. Stop with me for just a minute, and let me tell you what a lot of my work that I do is. I work in 3 different realms at Weimar. At Weimar, we have a medical clinic and a residential lifestyle change program. I work with some of those programs there, not with all of them, because I also teach in the college. We have a small college at Weimar. And then we have an intensive training program, a 4-month training program where we train health professionals and other people to be health leaders in their local church, or health support people in a local church or a medical practice or whatever, to be more evangelistic. So one of the things that I do when I give presentations in the community, I'm trying to get people in the community who have an interest in health more connected with the church. And there is so much literature like this, research, that connects many of the common diseases with lack of social support, that this is a very honest way to tell the community, you should come back to the program we're doing in this church next week, because one of the things that you want to do is increase your social connectedness. Here's a group of people. Let's say you're in a church hearing a health lecture from me. And I say, I want you to come back. I want to invite you back because next week we have a cooking class. You may not be all that interested in cooking, but part of the solution to your high blood pressure or your diabetes or your stress is social connectedness. And so being with people who value the things that you do. We're all here together in a health class. This is a value. You may not have that at home. You may not have that in your workplace. So I think this is very interesting, and it's a very good way to connect people with other activities that you're doing as a church. Well, it's not just, of course, in Europe that you're finding this connection between social connectedness and health. This is another study. We will be speaking more about cancer in this conference. I think there's a whole workshop on Friday where we'll be addressing this. But this is from that Nurses' Health study that we spoke about earlier, published in one of the English oncology journals. And what you see here in this particular study, they're looking at a host of women, nearly 3,000 women in this study who were diagnosed with breast cancer in a 10-year period. Actually, probably more correctly, 11-year period. And during that same window, they assessed social support. Now, here's the question. Was there any connection between social support and their prognosis, how they did with the breast cancer? Well, let's look and see what happened. What they found was simply this. Both all-cause mortality, so death from any cause, as well as death from breast cancer, was significantly related to social connectedness. Women that were more socially connected, they were these orange bars. They had the lower rates of mortality, while those who were socially disconnected, they had anywhere from 60% increase to over doubling their risk of mortality, depending on whether you look at all causes of death or breast cancer. So again, this is just a sampling of research that's out there. It's a huge body of literature looking at social connectedness. And what I'm telling you is when we blame our programs for not helping people to change throughout their life, we're missing what the research is telling us. I made a comment about this in the panel discussion that we had. And the point is, if we're not engaging our churches in health ministry, we are depriving our communities of this social support network. And I could tell you some stories. Maybe I'll tell you a story right now. A fellow I want to tell you about, I'll call him Bob. That's not his real name. But about 2 years ago, Bob came to Weimar. He came to go through our 18-day residential program. He had a nicotine addiction. He was a smoker. He was overweight. He had a lot of health issues. And he was not a Christian. He was not a Seventh-day Adventist, but he came through our program. And he got a lot of help. He stopped smoking. He felt better. He went back home. And he kept some connection with Weimar. Every month, we have an alumni group, people in the area that have gone through our programs, and we have this support network for them. We decided this year to offer a special Bible study class. I was going to teach this class along with one of our Bible teachers at Weimar. We were going to go through the Gospel of Mark, especially looking at connections with health. And so we invited all our Weimar alumni in the area to come back and go with us on this journey through the Gospel of Mark. One of the reasons we told them that this would be good is because it's giving them more social connectedness. Really, and we were honest with them. We're going to be helping you in an area that the medical literature is saying we need help with. So we had about 6 or 8 of our alumni who came back to this small study group. And we studied the Gospel of Mark for about 8 weeks. And then we were doing some other programs in one of the Adventist churches, and Bob went through that series on Mark, and then he started going to this health series, actually a CHIP program, and that we were running, that Weimar was running in one of the area churches. And the last Sabbath I was in the Weimar area, I was preaching at that church, and Bob was there for the Sabbath morning. I tell you that because he's becoming connected to the Adventist community there and the Adventist church, because the church, local church, has taken ownership in health ministry, and Weimar is taking ownership and doing something on a longitudinal basis. Let me just mention this as an aside, because some of you saw I got a little disturbed this morning. And I talked with Dr. Hart afterward. It wasn't his fault. He had gotten some information from the people that lost the vision to run the Lifestyle Center of America as a ministry. And of course, they didn't think it had anything to do with their loss of vision. They thought I left probably because I didn't have the right vision. So, we have some differing opinions perhaps. But here's why I'm mentioning that context for you. At the Lifestyle Center of America, before there was a change in philosophy, we were starting to move in this direction of taking long-term responsibility for the patients. I had actually implemented a team of people who were going to be calling on the phones, following up with our patients. When I left, when I started seeing that they were moving away from a ministry model, they not only got rid of all those people that I had brought on board, but they said we can have one person do it who had other responsibilities. They collected some data on follow-up, and now they weren't supporting them. They were just, quote, collecting data. And what they did is they collected data to tell people that the program didn't work and they had to keep coming back every year. This was their business mindset, that you can't just come for one program and then change your lifestyle. You've got to come back every year. Now, how well do you think that would go over with people? Well, it may sound like a good business strategy, but it's really not. And I'm simply making a point here. the point is, if we're not investing in people long term, if we think that we just come to our church and we give them a health lecture and they're going to change their lifestyle, no, this is not wise. If you're a medical practitioner, you say, well, I talked with that patient about losing weight 5 times. They still haven't lost weight. I'm not going to do it. Well, what are you doing to help them lose weight? Do you see? Are you having cooking classes? Well, you say, I can't have cooking classes in my office. I don't have the staff to do it. Well, what about your local church? Do you see? We need this partnership, and this is what the world needs. These are why people are not successful. They can make changes, and they're not sustained because they don't have the social connectedness and the social support network. Isn't it interesting that the Bible recognized this need for social support? Now, granted, it's in a spiritual context, but Paul is writing to the Hebrews, and he says, what? Let us consider how to stir up one another to love and good works, not neglecting to meet together, as is the habit of some, but encouraging one another, and all the more as you see the day drawing near. What is Paul speaking about here? He's speaking about social support, about social connectedness. Now you say, well, Dr. DeRose, I don't go to church anymore because the preacher is very boring, and they're not teaching the true Adventist message in my church. That's why I don't go there. I just stay at home and I watch one of those television preachers. You know, there are many wonderful Adventist preachers now you can watch on the satellite or on the internet. And so you say, I just stay home and watch them. Well, that's not following the counsel of Paul in Hebrews. He wants us to be connected. If there's problems in your church, maybe you need to be there even more. Because if you weren't getting ministered to in your church, how about some visitor that shows up? What would happen to them? You're needed there. Well, you heard about sanitarium health and well-being this morning, and I wanted to just remind you, regardless of what particular thing flashes up on their home page when you navigate there, that I'm encouraged that I see many of our Adventist institutions trying to take more collective vision for health, and sanitarium, you know, is now running the CHIP program. Dr. Hans Diehl, who many of you know from his German roots, started CHIP. Actually, CHIP, what I'm told in the history, was significantly modified by churches and church members and pastors, giving Dr. Diehl feedback. And now it's actually a part of our church through Sanitarium, which is a church entity. And impressive data from CHIP. If you look here, this is actually right from their web site. And I think there's a whole presentation on CHIP tomorrow. Is that right? Am I oriented correctly? Friday? Okay, Friday. And what you see here is you see dramatic changes in weight. And this is a 4 to 8 week program, typically as CHIP is run. And you notice that the people who have the greatest need to lose weight tend to lose the most. This is what Dr. Dan was alluding to earlier. Cholesterol changes. These are large numbers of people. This is pooled data from multiple CHIP programs, if not just in the U.S., beyond. I forget with this particular data set if it was just U.S. or worldwide. But you can see here dramatic changes in these numbers, just like we saw in residential programs. LDL cholesterol levels. Remember, I'm telling you about Bob. Bob came to Weimar. He was in an 18-day program, got dramatic results, but then he took a CHIP program, and he got even more results there as well, and he's sustaining those. It's now 2 years out. He's lost more weight, and he's growing spiritually. When he was in the Bible study with us on the Gospel of Mark, he'd never studied the Bible before. But here he is studying the Bible with us. And if you've never studied the Bible with someone who's reading the Bible for the first time, they ask you all kinds of interesting questions. Like when we read about how Jesus healed the blind man by putting spit on his eyes. He said, you know, I'm new to this. Is that how Jesus always healed? Did he always spit on people or put spit on things? No, really, I mean, it's just an honest question. And so, but what I'm saying is you look at data like this and you see that we have these resources in our church. You might say, well, I don't like CHIP. I don't like sanitarium. I don't like Australians. And Dr. Diehl, he's German. I don't like Germans either. And so I only like people that speak my first tongue. I only trust them. Well, listen, it doesn't matter what, do something. And it's easy to run a prepackaged program, whether it's depression recovery that our president, Dr. Nedley, has developed, whether it's CHIP, whether it's 8 weeks to wellness. That's another, an 8-week program that's designed to go through the basics of the Adventist lifestyle message. The point is these programs, not only do they have demonstrated results, as we're seeing here with CHIP, but they're a powerful vehicle for social support. Well, since we're talking about some of these connections, I wanted to show you a video clip from our recent program. And before I do that, I'm going to tell you about one other dimension to Weimar. More than one of you actually has come up to me and you said you want to get some exposure to Weimar, you want to go through a training program there perhaps. Let me tell you the two easiest things that I can offer you. One is a professional observership. We have people all the time coming from all over the world who go through our 18-day program as a professional observer. So that's an option open to you if you're a health professional, because you'll be involved in the medical meetings and things like that. If you're not a medical professional and you're wanting more training, or if you are, we've had physicians go through this program and others. We're building on something else that the literature is now talking about. And this particular study I want you to see, because it again is an illustration from high blood pressure, and I was feeling like some of you were feeling deprived, that we hadn't spoken enough about high blood pressure. So this is a really interesting study that was just published last year in the Journal of the American Board of Family Medicine. Here's the title of it, and I want you to pay attention to the title. The title is Delegating Responsibility from Clinicians to Non-Professional Personnel, the Example of Hypertension Control. It's very interesting. We've been talking some about this in the panel discussion earlier today. Remember the question, the healthcare climate in the world, in the Western nations, how can we deal with this? Technology is increasing the price of it more rapidly than we can pay for it. What are we going to do? They're looking at this problem, and they're saying the solution may be in training non-professionals to be involved in healthcare. So I'm not going to read through all this, but what they're saying is in this slide is in America, if we were going to do an adequate job of taking care of high blood pressure, the average physician cannot give the high-quality preventive services to those patients that include adequate care for high blood pressure and other chronic diseases. So what do? One solution they're recommending is to delegate less complex activities from physicians to other members of the primary care team so that the team, not solely the physician, becomes responsible. You say, well, that's obvious. We have other people on the team. No, they're talking about actually physicians hiring health coaches. Now, do you have a health coaching movement in Europe? Yeah. Okay. We have it in America, but they're not working for physicians. They'll work in health clubs or other things, and they'll be a health coach. They'll help motivate you to exercise and help you with your diet. Well, what these researchers are saying is we need to pull them into the formal medical system. And so what you can do is you can have a lot more people. They don't have to spend 4 years in training. They don't have to, have a nursing degree. They don't have to have a medical degree. But they can work closely with the patients. What we're doing is we're taking this concept at Weimar. This is what we're doing in our 4-month training program that we call Health. And people come to that program. This is the website. It's newstartglobal.com. And here's the health program. What we do is we train people to be health coaches. We train them how to run CHIP programs and depression recovery programs. We train them to go back to a local church and help lead out in health ministry. If they're a health professional, they may be perfectly equipped to be the leader of health ministry. If it's someone we have people, at our last class, the class is actually graduating this weekend. They acted disappointed that I'm going to be here with you. But I told them I hadn't even met any of them 4 months ago when I agreed to be out here. So they weren't supposed to take it personally. But the point is, one of the people graduating is a businessman. He left his business because he wanted to be more involved in health ministries, taking our 4-month program. Another person's a social worker. She wanted to get more involved in health ministry. We have a physical therapist going through the 4-month program. We have people who've gone through the program, actually several physicians went through our last program, nurses. And then we have students who are right out of high school, who come, before they go to college, they want a training in health ministry. So the class actually looks like a church. I mean, we've had people in their 70s in the class as well as, 18-year-olds. So what I'm just saying is this program, you don't have to come out to Weimar to do it, but Wildwood does some similar training programs. Herghelia, aren't they still running training programs there at Herghelia? They still have a training program there. So there's other things here that are accessible, and whether you take advantage of those here, whether you grow abroad to get those. I want to give you now, with that background, some of this interconnection. But you have a question before we go there.
Sorry, how long does this take?
Okay, this is a 4-month training program. So most professionals can't get away for 4 months. They'll come for the 18-day professional observership. But if someone's at a transition, the 2 physicians we've had that have gone through the program, they've been transitioning in their practice, wanted to get more training and working with the church and be more involved in church-based ministry. They've come through that program. So what I want you to think, though, it's not so much about what we're doing at Weimar, it's what anyone can do anywhere. What I'm saying is you can train people here locally in Europe to be involved in health ministry. I know some of that's happening, but more could be done. You don't have to train them to be physicians. You could train them to work with physicians as health coaches.